Professor Frame, in your clinic you see a number of patients, and you know, I presume it's very important to give them the options. You know, you hear of these stories where patients aren't completely informed and are not given the options. I mean, do you go through what sort of implants that you will be inserting into the patients?
Yeah, I think in today's litigious society, you've actually got to show everybody that's interested in having this type of work. That's the cosmetic augmentation as well. You've got to get them to understand the history, understand where we have been and where we actually are now, and then actually I think you've got to show them the complete variety of implants that are available, because each of them has advantages and disadvantages. And also, if we're talking about breast cancer and reconstruction, you know, it's very easy for me to sell somebody that moves a block of tissue from the tummy to the breast as saying, you will have a tummy tuck at the same time as you're having your breast augmentation. But what people fail to tell you, there's at least a 30% complication rate of having that type of tummy tuck moved up into your chest wall. And if I were a woman, I wouldn't particularly want that. And I also wouldn't want to have an operation that delayed healing, that delayed treatment for my cancer. And I wouldn't want an operation, by and large, that may still need an implant, even though you've gone through that 12 hours of quite risky surgery. So I cannot see any advantage in most cases of today's philosophy of how you manage or excise breast cancer. I can't see many reasons to actually move a block of tissue up when we know we've got a very perfectly adequate implant that should suffice to cover most women having mastectomy reconstruction. There are times when you need a flap, I understand that, and there may be times where it doesn't give quite a desired result, because part of it is related to the structural anatomy you start with, and the surgeon that does the mastectomy, how much he has to remove and how much he mutilates the tissues, what sort of space he leaves. But by and large, today's breast surgeon is actually a little bit more savvy with blood supply to skin flaps, making sure there's a thickness there. Where is the breast within that skin flap? You know, you preserve tissue, you don't handle tissues badly. There's absolutely no reason why you can't put a polyurethane implant straight into that space and you're finished. And the cost implications are huge, because an implant will cost you £350 or something like that, whatever the equivalent is. You know, a free flap procedure is £15,000, I mean £20,000.